This is a 32-year-old male, a known case of type 1 diabetes mellitus, who was brought to the casualty with drowsiness, fever, abdominal pain and vomiting. On examination, the patient was confused and clinically dehydrated with a dry mucous membrane and poor skin rugosity. His pulse rate was 104 beats per minute and blood pressure was 100 by 70 mmHg, suggesting volume depletion. His respiratory rate was elevated and he was febrile. Rales were present over the right lower chest, suggesting possible lower respiratory tract infection. And atrial blood gas showed severe metabolic acidosis, and urine analysis showed glycosuria and ketonuria. The electrolytes level were also abnormal. Overall, the patient has severe hyperglycemia, ketonuria and metabolic acidosis, along with clinical dehydration and altered mental status, which probably suggests diabetic ketoacidosis. So today let's discuss about the diabetic ketoacidosis. It is a life-threatening metabolic emergency caused by severe insulin deficiency. It is mostly associated with type 1 diabetes mellitus, but it can also occur in type 2 diabetes, particularly during severe physiological stress. So what triggers DKA? So the common precipitating factors include infections, pneumonia, urinary tract infections, sepsis, gastroenteritis, inadequate or missed insulin, and acute pancreatitis, myocardial infarction or the cerebral infarction, severe physical or emotional stress, pregnancy, hyperthyroidism, pheochromocytoma, drugs like corticosteroids and thiazides, alcohol or cocaine use. So the most important trigger to remember are infection and adequate insulin therapy. Now, why do these triggers cause DKA? During infection or severe stress, the body releases counter-regulatory hormones, particularly glucagon, catecholamine, cortisol, and growth hormone. So these hormones act against insulin. Therefore, DKA develops because of insulin deficiency and excess counter-regulatory hormones. So this is the basic starting point. Next, what happens when insulin is deficient? Normally, the insulin helps glucose move from the blood into the cells so that it can be used for energy. So this is how the energy production occurs. But in DKA, insulin is deficient. Therefore, glucose cannot be utilized adequately by the insulin-dependent tissues. At the same time, the liver is receiving signals from glucagon and other stress hormones saying we need more glucose. So there is a compensatory or alternative mechanism for energy production. So the liver increases glycogenolysis, which is breakdown of stored glycogen, and gluconeogenesis, which is production of new glucose. Okay, there is breakdown of the stored glycogen as well as there is production of new glucose. So therefore, two things happen simultaneously. Glucose utilization decreases and glucose production increases. This results in severe hyperglycemia. So why does this hyperglycemia causes dehydration? Now we have to come to the next important step. When blood glucose becomes very high, the kidneys cannot reabsorb all the glucose. So glucose starts appearing in the urine. This is called glycosuria. Glucose in renal tubules pulls water along with it. This is called osmotic diuresis. So hyperglycemia causes osmotic diuresis that leads to excessive loss of glucose, water, electrolyte in the urine. Okay, this produces severe dehydration and volume depletion. This explains why the patient develops polyuria, polydipsia, dry mouth, dry skin, tachycardia, reduced JVP, hypotension, weakness, and eventually shock. But why does the patient form ketones? So this is the important part of DKA. Insulin normally suppresses fat breakdown, but when insulin is deficient, lipolysis increases. The stored fat is broken down into free fatty acids, and these free fatty acids travel into the liver. In the liver, they are converted into ketone bodies. Okay, when the production of ketone exceeds the utilization by the peripheral tissues, ketone accumulate in the blood. This is called ketonemia, and the ketone also appear in the urine, which is called ketonuria. Next question is, why does the patient become acidotic? Acetoacetate and beta hydroxybutyric acid are acidic substance. Okay, I mean the ketone bodies are acidic substance. So when they accumulate in large amounts, hydrogen ion increases. The bicarbonate buffer system tries to neutralize these excess acid. Therefore, bicarbonate level decreases. This results in metabolic acidosis. So now we can understand the three cardinal features of DKA, which is hyperglycemia, ketosis, and metabolic acidosis. Hyperglycemia is because the glucose utilization decreases and hepatic glucose production increases. Next, ketosis is because the insulin deficiency causes lipolysis and increased ketone production. Metabolic acidosis is because the acidic ketone bodies accumulate. Now that we have understand the pathophysiology, the clinical features become easy to understand. The patient may initially have symptoms of hyperglycemia, which is polyuria, polydipsia, weight loss, weakness, blurred vision, and because of dehydration, we see dry skin and dry mucous membrane, tachycardia, reduced JVP, hypotension, cold extremities, poor peripheral perfusion, and because of ketosis and acidosis, we see nausea, vomiting, abdominal pain, Kussmaul's respiration, and fruity odor. As the condition becomes severe, there is lethargy, confusion, altered consciousness, shock, and even coma. Cerebral edema is the most important but uncommon complication, particularly in the young patients. The patient with DKA has usually lost a large amount of potassium through urine, osmotic diuresis, and vomiting. Therefore, the total body potassium is depleted. However, when the patient first present, serum potassium may be normal or even elevated. Why? Because insulin deficiency and acidosis cause potassium to move from inside the cell to the bloodstream. Therefore, serum potassium may be high even though total body potassium is low. Once we start the treatment with insulin, the potassium moves back into the cell. Therefore, serum potassium can fall rapidly during the treatment. This is why potassium must be monitored carefully and replaced when indicated. So how do we diagnose DKA? So the typical findings include elevated plasma glucose, increased blood or the urine ketones, and the atrial or venous pH is below 7.3, and there is reduced bicarbonate levels and increased anion gap. The patients may also have elevated urea and creatinine because of dehydration, leukocytosis due to stress, abnormal sodium and potassium, elevated serum amylase in some patients. So we should also look for the precipitating cause. Therefore, depending on the clinical situation, we investigate for infection, MI, pancreatitis or other acute illness. And ECG is very important, particularly because potassium abnormalities can produce dangerous cardiac changes and myocardial infarction may be a precipitating factor. The major goals of a treatment include restore the lost fluid volume, give insulin and stop the ketogenesis, correct potassium and other electrolyte abnormalities, allow the acidosis to resolve, find and treat the precipitating cause, and monitor and treat the complications. So coming to the brief management, first is the fluid resuscitation. It is a major component of the treatment. Okay, so the major component of the treatment is IV fluid replacement. Why? Because the patient have lost several liters of water and electrolytes. So the fluid replacement therefore restores the intravascular volume, improves the tissue perfusion, improves the renal perfusion, helps clear the glucose and ketones, and help correct the dehydration. Usually, a saline or other appropriate isotonic crystalloid is used initially. Coming to the insulin therapy, it is a second major treatment. Insulin is not given only to lower the blood glucose. Its most important role in DKA is to stop the lipolysis and stop the ketone production. As insulin is given, the blood glucose will fall, but the ketoacidosis may take longer to resolve. Therefore, once glucose falls to lower range, dextrose may be added to the IV fluid while the insulin is continued. Why? Because we still need insulin to suppress the ketogenesis and clear the ketones. So dextrose allows us to continue the insulin therapy safely until the ketoacidosis resolves.